I would like to invite to the stage Lisa Stevens. So Lisa, come on up and take a seat. Lisa is the Director of the International Atomic Energy Agency, IAEA. And also Yolandi Leviens, who's the Chair of Radiation Oncology Department at the University of Ghent. Hi.
Yes.
So we've got a interesting session today talking all about radiotherapy. We've heard a lot about pharma, with the pharma side of things. Heard a lot about the European Beating Cancer Plan, and also all the different issues we have around connectivity, data, digital, and the continuum of care. So I'm going to pick up on that a little bit further as we go through the conversation, but it'll be very much a conversation, and it can go wherever we like. I'll try to keep some level of agenda, and we'll see if Patricia joins us, we'll bring her into it as well. But this session today, we're really trying to look at how we improve outcomes through advances in radiotherapy. What are the cutting-edge radiotherapy solutions that we've got at our disposal? So how do we bring this into mainstream? Are they mainstream? Should they be? Is another question. And also looking at how they improve outcomes. Are we able to bring these cutting-edge innovations into the market and showcase an improvement in outcome, which is a fundamental issue? Also, how to ensure equity in supply and equity of access. So it might be one thing to have the supply, it might be another thing to actually be able to access that. So therein lies another issue. We can't do a lot of this without, or any of this really, without referring back to the COVID problem. We all know what happened when the hospital started to shut down, and access to services therefore went with it. So we have that issue to deal with as well. So I'm going to refer to COVID as a learning opportunity for us. And then lastly, if we've got the time, we will talk about digital solutions and how to improve efficiency through the digital solutions also. So that's the agenda. I wanted to start without Patricia, actually referring to one of her quotes that she sent me with some of the material that I got to prepare this session. When all paradigms are no longer working, we must look towards new innovations and new approaches. So that's something that I think we hear a lot about with radiotherapy is we've got all of this influx. It's one thing to be bringing drugs, it's another to bring a massive machine into the market. It's also another to bring a machine in protocol and the way that we use those machines, SABR, stereotactic, that sort of thing. And then Yolandi, you sent me something as well. An optimal combination of clinical, translational health service research is required, and that's key to the future of radiotherapy. And I think that harks back to the discussions that we've had earlier on today about actually taking what we do in research and then translating that into real practice, but then validating it as well, that it is delivering an actual optimal outcome. So I'm going to go straight to you, Lisa, if that's okay.
Sure.
Straight off the bat. So looking at equality and equity across the cancer care continuum, can you tell me a little bit more about the Raise Our Hope, and particularly referring that back to the cancer plan that we've heard so much about across this forum? What is the initiative between the IAEA and the European member states? What are you trying to achieve?
Sure, thank you for that. So I'm delighted to be able to talk about Rays of Hope because I think it gets at what you were saying in terms of equity of access, but also links back to what Pat mentioned in her quote about the paradigm shift. So the International Atomic Energy Agency has been supporting member states to either initiate or expand radiotherapy for 60 years. However, the paradigm shift is really looking at how can we, in a more concerted and collaborative way, work with our member states for that initiation, so maybe for that first radiotherapy center or for expansion, so improving the equity of access. And this all has to be in the context of comprehensive cancer control. So this is how it links into the medicines discussions that we've been having, the research, the utilization of data and AI, is that it's not just about delivery of a machine. It's making sure that you have the trained personnel, you have the quality assurance. And another term that I heard yesterday was sustainability. So through Rays of Hope, because we're looking at this in a slightly different way, this integration across our safety technical staff, our nuclear application staff, the staff who work with the member states very closely, and saying, how can we do this in a sustainable way so that a center that opens will be open in 10 years? That you have the quality in terms of the staff. And one of the key parts of Rays of Hope, which is different, is that we're building in anchor centers. So these would be regional centers that would be able to provide training, that would be able to support quality assurance, would be able to support research, provide experts for regional missions and regional activities, and also would be able to provide both diagnosis and treatment services, again, for members in the region. And I found the discussion on the EU Beating Cancer Plan and the network of cancer centers really supportive and linking to what Rays of Hope is aiming to support. And then if there's time throughout, I'm happy to talk about a relook at the partners that we want to bring around the table to make sure that we're able to implement this. But I think those are some of the key points in terms of the European context and Rays of Hope.
So very much about bringing together not just a network, but that network is functional, it's sustainable.
Correct.
And fundamentally it has an optimal governance structure, and it's governance and continual learning structure as well, so that our staff who are critical to everything we're doing are able to deliver the best to our patients and socialise that, because the staff move around as well.
Right.
It's not just that they'll stay in this particular centre too. I am delighted to see Patricia on the screen here. So apologies for the issues we had technically, but it's great to see you here. We just started without you, and Dave gave a quick introduction. I also provided one of the quotes that you gave me in the information that you sent prior. So I wanted to very quickly, just since you've joined the conversation, point a question to you, Patricia. With regard to the cutting-edge technology, because we often talk about radiotherapy and the advancements and the machinery that we've got, and Yolandi and I were talking here over lunch actually about, you buy a radiotherapy machine and it lasts for a good 10 years, in theory, before innovation comes up, and even then you can retrofit things to it, and of course we change the protocols that we utilise on those machines as well. So as sweating the equity, as we like to refer to it, there's that opportunity. But from your perspective, what do you think are the key developments that we've seen with regard to the novel developments we've got in radiotherapy, and are they actually resulting in improved outcomes?
Yes, no, well, thank you. And I'm talking here on behalf of the Global Coalition for Radiotherapy, and we've just produced our white paper just specifically looking at this issue. And we're a group, it's getting together of basically the whole of the radiotherapy family in the world, from individuals to organisations to industry to patients, to really be thinking through. Really, we need a digital transformation in radiotherapy. Of all the medical disciplines where technology has completely whizzed on in the last 10 years, it's radiotherapy. And I think now we can capitalise on this. I think COVID has shown us that we are all able to access this type of thing. And so now let's kick on there. I think in every aspect of radiotherapy, as you say, the machines themselves, well, operationally, there's so much more remote support we can give now. Things like I know in the Ukraine situation, I know the industry have been remotely supporting them there. In terms of actually how we deliver the planning, so much now can be done remotely, and then actually even people could remote plan and then just distribute those plans down the line to machines elsewhere, opening up a whole lot of new areas of expertise where you don't have to have all the expertise on the ground in one place. Then, of course, we've got training and education that can be done digitally, and really what we feel with the global, there is a lot of people out there willing to help. And so it can now be accessed worldwide in terms of training and support. And then, of course, in terms of digital MDTs, making those decision making. So on every single aspect, from the machinery to the software, even workflow, there are digital solutions which, if we combine all our brains together, this could look very different indeed. And then hopefully we can improve access, actually put that decision making in there, and also we can close that care gap, we think. And then there's so much happening in radiotherapy, with immunotherapy and also with the new charged particles where you may get differences in actually the immune response. There's a great future, but if we hit it hard now with the digital transformation, this can make a big step change.
That's really interesting. So something that stands out here is where it comes back to both of what we've said before about the network, and you mentioned about auto planning, well, not auto planning, but potentially remote planning. The digital libraries we have of plans, so you can pull up plan of the day, the adaptive planning. And for those of you who don't know what that really means, is if we've got a plan or a series of plans that we've done for radiotherapy, then we can choose the plan of the day. That depends on the anatomy of that patient. Also to cross-reference other plans that may be suitable for that individual over time, and building up a library so that you can automate to an extent the plan of the day or the optimal plan for that patient before it gets near an oncologist potentially, so that they can do the further plan optimization. That goes back into the library, and then we've got this virtuous cycle of optimization. The other thing I'd bring up is also the potential to follow the sun. So if we've got the issues with regard to the 9 to 5 or 9 to 6 radiotherapy department, the planning can be done overnight in another jurisdiction or overseas. So further optimization as well. So Yolande, I haven't forgotten about you. I'm coming.
Very confident
you don't get off the hook. So I think a comment that really sticks in my throat as a radiation therapist is when somebody said to me, radiation is the poor cousin in the cancer pathway. Why are we always forgotten? Why are we the last thing that people consider after surgery or immunotherapy, et cetera, et cetera? So you mentioned about translational health and translational services research. How do we make sure that isn't the case and that radiotherapy is actually brought up right at the fore around the patient decision-making for optimization of that treatment? You're also talking about the value of this with regard to your study with Estro and the value-based healthcare side of things. So one is taking this translational approach, the study of research into actual service, and the other is turning that into a value proposition so that we can showcase the value of that. I wonder if you can talk a bit more about that.
Yeah, thank you, Matt, for bringing this up. Yeah, obviously, I think that there's an enormous amount of research that is being done in radiotherapy, bringing the clinical benefits into the picture. So there's an enormous amount of data there. But translating it into the health system very often remains a bit of an issue. And maybe we can come back to that later on. But for example, the hypofractionation, where we have had a lot of data already available, has actually been, leveraged by the COVID situation, because this gave us the opportunity of treating patients in a more condensed way, avoiding them to have to come to the hospital too frequently. So sometimes we have difficulties in translating the evidence that's out there in the literature into the health system. And I think that therefore we need, like every other treatment in oncology and beyond, we have to appraise the value of it. And I think it's extremely important to understand that the dynamics of this appraisal are completely different from the pharma or the drug industry, because typically for a new drug, before a healthcare provider starts to use it, the whole appraisal has been done. In radiation oncology, it's typically the inverse. It's typically the healthcare provider that buys a new machine, a potentially machine with new potentials and new opportunities, but it still has to be proven in certain patient populations. And this proof, or the load of this proving, is really in the hands of the healthcare providers typically. So the dynamics are completely different. And I think very often people think, there's value scales that have been used very broadly for pharma and that has been developed, like the ESMO magnitude of clinical benefit scale. But the problem is that they have been typically developed from the point of view of, indeed, medical oncology, of how to appraise drugs, whereas radiotherapy treatments are different. And so just a few things to mention. For example, many of these evidence has been really focusing on randomized controlled trials with outcomes that are survival or event-free survival or toxicity, whereas for radiotherapy, if you look at the outcomes, they can be quite at the later stage. We improve our treatments, we improve the survival, but we also decrease the long-term toxicities. And this proving and this, well, evidence generation takes a while. So just translating what you do in drugs in that perspective is not the same. Also, many of our innovations are not always stepwise. There's a lot of incremental changes that progressively evolve. So we have a very broad span of innovations in radiotherapy that can go from a completely different machine to new masks or hypofractionation or combination with new drugs. So the span of treatments and innovations that we bring is very, very broad. So we have to appraise that. And then also we have to understand that using these machines, well, it's not only the machine, it's also the people who use the machine. And there's a learning phase. We have to educate people, we have to get people abreast of these new technologies and knowing how to use this in a qualitative way. So there's really an operator dependency that is extremely important in radiotherapy, which you have to a lesser extent, I would say, in terms of new drugs. So all these aspects are very important in appraising new radiotherapy. And therefore, I think it's very important that we start thinking on how to do that and not just, well, base ourselves on what is there, what policymakers probably would do and say, well, we have value scales, we'll use them. Well, they do short to radiotherapy. We really have to think on how to develop a value scale that is really looking into the benefits of radiotherapy and the needs of evidence generation. That might be randomized controlled trials, but may also be generating a lot of data in the real world setting and having a blended approach to evidence generation. So I think as a radiation oncology community, this is one of the things that we have to do, and we shouldn't do it in isolation. Maybe we can come back there later on. I mean, it has to be in consultation with other oncology specialists, of course. I mean, it should not be something that is standalone, but it should take into account really the specificities of radiotherapy, which are quite different than new drugs, for example.
So quite interesting when the point I'll bring up at the end is around multidisciplinary approach. So fundamentally, radiation therapy should be right in the centre of the MDT discussion as well.
Obviously.
So obviously, as you're coming into the cancer pathway and you're making decisions as to whether it's adjuvant therapy or whatever the case may be, does radiotherapy play within that? Equally, you're talking about efficiency. I don't think we can do too much discussion without looking about the optimisation of the clinical pathway or even the disruption to the patient's life. I'll take a step back to COVID very briefly, and of course that disrupted everything that we did in oncology. My busiest 16 months of my professional
16 years.
Yeah, 16 years.
Felt like 16 years.
That's what it felt like, didn't it? Yeah. The first 16 weeks of COVID was the busiest of my career, as we had all of our hospitals shut down, and we've got patients in the middle of treatment, etc. So one thing with regard to chemotherapy was, okay, do we or do we not give patients this toxic systemic therapy, but how does that reflect on patients still being eligible for radiotherapy, which of course is targeted, and therefore you have a different side effect issue. And with regard to efficiency, patients who might have been on a 15 fraction treatment or 15 treatments regime, or even a 24 or a 42 in some cases, could be delivered a much quicker stereotactic or SABR approach, and having patients coming in for treatment for only one part of the day for 1 week, as opposed to potential weeks. And Patricia, I'll pass this over to you at this point around how you think we can take the learnings that we had with COVID, because it was this complete social anomaly that we all had to adjust to, and use those learnings going forward, particularly, and I pointed about the SABR and the hypofractionation, etc., but how we became a super efficient model at that point out of pure necessity, and how do you take that forward into mainstream practice now?
Yes, I think you're absolutely right, because a lot changed in radiotherapy. I think partly in terms of our remote solutions, and I think we all communicated quicker and faster, and so plans were being discussed and all this type of thing. And I think we mustn't lose that. We must know that we can do that. We can talk to colleagues instantly. You can have images there, and you can make faster decisions. So that bit of the process is there. I think it also stimulated industry to move very quickly into their AI solutions, all these things that will make things faster, and in some ways be able to be remote. And I think the issue, we had a very good webinar with the Global Coalition about hypofractionation. And so I think it's really set it up as a less fractions. Where is the evidence for less fractions, and where is we need to put more effort into there? But certainly it really pushed centres that perhaps hadn't been quite got their sabre right into actually, right, we'll do it. And also what's been amazing is now just published from Holland, and I know we've done it once in the UK, single treatments for lung cancer. You know, come in on a day, have everything done, have your treatment, and leave. Now, that type of thing, you would not think, before COVID, you wouldn't think that was the direction we need to go. And then suddenly with COVID, it is. And I think we've got to think about what next after the pandemic, because I think there's always a concern is that, was that the last one, or might something come along? And perhaps that separation of cancer services from acute services in some respects. So thinking now along the lines of, I know in the UK, we're going to have these community diagnostic hubs so that people would be safe having imaging away from acute centres. You know, should you be putting radiotherapy machines in there too? So you can have this very fast treatment, get them diagnosed, get the plan. So I think it's given us a reason, and I think more so now because most places now, the whole pathway disrupted. I know in the UK, our 62-day targets are not being met, but we need to do something radical now to make sure we're getting through these patients and giving them the curative treatment. As there's that very good work from Dr. Wall on every 4 weeks delay in treatment, diagnosis and treatment, to be up to a 10% reduction in survival. So it's been like COVID's like a big bell ringing.
Patricia, just so you know, you're sort of ducking in and out. We do have a couple of connection issues at this, but I think we got the gist of what we were saying here. Did you have a comment, please?
Pick up on what Pat was talking about in terms of the hypofractionation. So we also see this as a way to more efficiently use machines that are in place. So in terms of the Rays of Hope paradigm, when you're looking at a country that doesn't have sufficient machines to treat their population of cancer patients, if you can implement some of the findings where you still have good outcomes, but you basically double the capacity of your machine, then you're increasing the equity. And it also brings up the partnership. So again, in looking to this EU Beating Cancer Plan and these networks of cancer centers, how can we all come together and form these novel partnerships? So with the private sector, which is something that IAEA has been interested in pursuing more, and we have some strong relationships now with the private sector, but they're doing a lot of training that we can capitalize on, and looking at also virtual modalities for training. So again, taking from what we learned from COVID, where we had to do it this way, not doing everything virtually, because there's something to be said about, you know, at some point being face-to-face, but are there portions of these trainings that can be done in these centers in a virtual way to limit then the time where someone has to be away from their practice?
Yeah, that's a really good point, and Patricia's back with us as well. So if we are looking at sweating the equity, I'll refer back to that again, but if we're looking at the training of a centre where we could bring in that ultra-efficient model, then the capacity issue starts to go away. And that's, you know, the days of 60 patients going through long-form radiotherapy should probably start to look at it, unless it's appropriate for the patient, then we can start looking at that as being a thing of the past.
Yeah, I just wanted to point out there that for the public, it's important to understand that, well, it just did not come overnight to go to this hypofractionation. This is really built on a very long trajectory of clinical trials that had already proven that indeed, for example, when I was training in radiotherapy, breast cancer was treated in 6 weeks and a half. Now it's indeed treated in 5 days, which is a completely different way of treating your patient, and which for the patient decreases the burden quite substantially, and the outcome is exactly the same. But you can only do that in a way without having troubles if you give the most optimal high-quality radiotherapy. So I wanted to just point out that this is very important, and hence the training of the personnel and the making it, available in a good training circumstances, good quality assurance. And then the other thing which I would also like to say, and which was the case in many countries in Europe, amongst others also Belgium, the fact that we can deliver in 5 fractions is also because reimbursement has now in Belgium been translated towards that. There was the evidence. We have a lot of difficulties in making that accepted by the policymakers. But now, due to the impetus that came through COVID, that reimbursement of a fractionation scheme with the same outcome, but with less burden for the patient and being very optimized in the context of COVID, suddenly was feasible. So there was a kind of impetus also from the health system translation that came into it so that we could do it, because otherwise we were really penalized in doing so.
And that's a really good part of the discussion I'd like to pick up on, because if I go back to the days when I was head of cancer for an insurer, I had a hospital call me in crisis from a financial perspective and said, if we move to 5-fraction breast, we can't now afford to give radiotherapy because we're paid by treatment. So there's actually a perverse incentive almost to give long-form treatment. It took a step back and say, well, hang on a minute, what we're delivering here is an episode of care. So whether you give 5 fractions, whether you give 25 on a protocol, or whatever it is that the doctor considers to be appropriate for that individual, it should be delivered in a package price.
Yeah.
And once we'd got that worked out with the hospitals for maintaining sustainability for their fund, which of course we can never get away with in all of this, somebody has to pay for all of this, whether it's the taxpayer or whether it's through the insurance, what have you, then that whole issue started to go away, and we saw a huge adoption then with 5-fraction or stereotactic radiotherapy. So it's worth bringing up that when we're talking about translational change, that we're not just talking about what we do with the research and the machines, that it needs to translate over to the protection and mechanisms between the payer and the provider, so that they're both working in partnership for the patient. Patricia, I'd like to point over to you. We've got a few minutes left, and then I'm going to hand over to the audience as well. We can't also discuss radiotherapy without looking at late effects and side effects and the whole personalisation and management of patients beyond. So COVID was another opportunity where we saw a takeoff, I guess, of the remote monitoring of patients and their needs, patient-reported outcomes toolkits, symptoms assessment, et cetera, do you think that those learnings are now going to be translated into clinical practice so that we can also maintain that, but also show the benefit of that back into...
You're absolutely right, because so much of the sort of hardware and software improvements in radiotherapy has been about more precision and more localization, so less toxicity, so we can actually give the right dose and the dose we need, and so we can improve survival. And I think reporting the outcomes is good, and as Yolanda said, there's years of work done on this, but I still think we've got to make the case to decision makers that actually side effects are important. And so much still is based on, I know our NICE system in the UK, it's based around drugs. It's based about short-term response. It's not about the benefits of improvements in late toxicity. So until we have that as part of our value, it's going to be quite hard. But for patients, it's absolutely important. And for our treatments, it's key to it. But we've got to change the narrative in what are we measuring and what are we valuing.
Yeah, and I'm going to quote a patient who said this to me once upon a time, who really made me think here. Matt, it is important whether I live or die well. Live or die, but what's important, but perhaps more important, is whether I live or die well. And that comes, and who is monitoring me thereafter to ensure that happens.
Or maybe a very short remark to what Pat is saying. Indeed, in terms of appraising the value, the outcomes that drugs and radiotherapy have are in part the same, but in part also very different. I mean, for us, for example, sparing a limb or sparing the glottis or sparing the breast may be an extremely important issue for the patient. It might, in some circumstances, not have an impact on survival, but may make a complete change in the way that they live the rest of their life. So it's a combination of, indeed, survival, local control, which is extremely important in radiotherapy, and then, indeed, decreasing the toxicity. So it's a whole package that is, and with that also the burden to the patient with shorter fractionation schedules. So it's a whole package of different outcome measures that are more comprehensive, I think, than just survival and quality of life and response rates.
And of course,
yes, I think we must remember that radiotherapy is needed in 40% of cures. So that means all those patients will be cured, and so their late effects do matter.
Of course,
and we've just got to change the narrative, because you look back on years how radiotherapy's moved over the last 30 or 40 years. It's completely unrecognisable.
Exactly. So I'm going to move quickly now to any questions from the audience. So we've got a little bit of time. We've got about 5 minutes. Mark.
Yeah, I absolutely agree with Pat. Hi, Pat. Good to see you again. And Yolanda, we do need to change the narrative. And I'm going to criticise you, Matt, for saying at the start that radiotherapy is sort of the sort of ugly sister or whatever. I think that's totally changed now. I think both Pat and Yolanda have shown why. Because it is targeted therapy, and it also cures more people than does chemotherapy. So it's really, we need to change the narrative. We need to forget about radiotherapy 30 years ago, which a lot of the narrative is still about outside the radiotherapy community. And we need to say, this is actually the way we're going to deliver more cures. And as Yolanda said, the sort of precision that we can use now is much more effective. One of the things that we still need to catch up on in relation to radiotherapy, though, is radiotherapy research and investment in radiotherapy research. And I think that's one area where if you look at the investment in systemic therapy as opposed to radiotherapy, there's a complete sort of logfold difference, and that needs to change. That narrative needs to change so that those new developments can then be mainstreamed, can be implemented into practice.
I think that's a really good point, because one of the issues I've had in dealing with the world of reimbursement is for a new modality to come into the market. We'll use MR-Linac as an example, and for a reimbursement model to come to a payer, whether it's NHS or otherwise, and to say we need to get a return of investment like any other innovation, whether it's pharma or whatever the case may be. And of course the response is prove the value. The response back is, well, give me time to do so. And the value isn't just regard to looking at toxicity, but also the holistic side of patients, the patient satisfaction, the patient-reported outcomes, but also reduction in toxicity in time. And that takes a bit of time to realise. And therefore, you need to be a data partner. If you're going to be a payer, whether that's NHS or otherwise, we need to be able to translate what we're getting in clinical outcomes into a value proposition for you in order for you to come back with the reimbursement. But if you don't do that, what can we do? Anybody else for any more questions?
While we get a question from the audience, I just want to pick up on what you said about investment and return on investment, because that's also changing the narrative. As opposed to the machine being a cost, you're actually really investing in the care. And that's a change of mindset for policymakers and decision makers. And again, as I said at the beginning, to make sure that radiotherapy is integrated into the entire cancer continuum. So it's not an add-on, it's not an afterthought, but it's really part of the care journey. And as Pat said, in 40% of the curative cases.
Yeah, I just wanted to add something also in terms of this evidence generation, that there's leverage that we can see through financing as well. I think we have to go to a blended approach to evidence generation, and for me, I'm a strong proponent of coverage with evidence development. So that means that part of the equipment, the investment of part of the operation is covered in return for generating evidence on the clinical benefits and evidence on the costs of the treatment. And there you build up an evidence throughout the use of this machine and bringing it at a very early stage, a potentially valuable novelty to your patients, but with with the provider really developing the evidence that is needed to then make the value proposition at the end of the journey. So looking into these ways of learning from every patient is extremely important, I think.
Yeah, that's a really good point. Gentlemen.
So I have a question related to accessibility. So I'm a nuclear physicist, and part of the research portfolio of the group I used to work in is developing radioisotopes that can be used in these treatments. And a lot of them, the amount that can be produced is very small. You might then end up putting these drugs into kind of an orphan category because it's so small and so expensive. In the US, the Department of Energy has an isotope program that works on developing new ways to produce more of these radioisotopes so that they can get out to more people. Like, for example, actinium-225, up until recently, only 10 people a year have been able to be treated with that. So that is a big accessibility question. So is there a similar program like this in the EU, or plans in the future for having better development of these radioisotopes that get used?
So we've got about 30 seconds to answer your question. So given that I might hand over to you, Lisa, and then last, if you've got anything to say, Patricia, and then we'll close up the session.
I would defer on
You want to
the
defer to
program on
Yolandi?
radioisotopes.
Sure.
Yeah.
Yolandi or Patricia, would you like to comment on the gentleman's?
Some of those now have been led by companies pushing. I know in the UK we've got a readiness program for more isotopes. So I think it is out of mainstream sort of technical radiotherapy, but I know some people are pushing, and obviously the more of that we can add to supplement it will be great.
Excellent, excellent. So, I mean, it comes back to the whole issue we're talking about is ensuring access. Right at the very start, we started with this access, equality, and provisioning. So, and of course, it's not radiotherapy machines, it's all the other radiation that we use in the therapeutic pathway as well. So, good point, thank you. We are finished up, so I'd like to thank Yolandi and Lisa, and also for you, Patricia, for joining remotely. Excellent, so thanks very much. Any other questions? Come up to us afterwards.